Hey, all right. Okay, so I fully recognize that I'm the person standing in the way of lunch, so I will try to move quickly so that we can all go eat. That's the University of Chicago. If you find yourself in the greater Chicago area, please stop by. For me, it's great to be back. This was from 3 years ago before the world ended with COVID, so it's nice to be back in India. These are my conflicts of interest for what they're worth. So what we're going to go through is talk about improving our yields, and that'll be brief. We'll talk about external imaging, the role and value of adding external imaging to bronchoscopy. We know it from our basics, general fluoroscopy, but trying to get beyond that. And then we'll start talking about what's new in robotics specifically, and in particular a new robot that's about to launch, and then its role within therapeutics. So why has the yield across platforms only had a modest improvement, even with the advanced technologies of robotics? Why can't we do any better? And as a nice quote actually from the good Dr. Mahajan points out, the best chance to improve the outcomes for our patients is to combine both robotics and imaging to raise diagnostic yields. And if not robotics, then even obviously better scopes, like a lot of the earlier discussions, combined with external imaging, and the ability to then see so that you can manage tool-to-tissue interactions. So needing to go deeper than that, let's talk about external imaging. So last night was a fantastic session discussing on the use of cone beam CTs and hybrid rooms and even mobile CTs. And how the value they provide. I'm going to spend a little bit of time briefly talking about another platform that's at a lower cost that involves using any C-arm to give augmented fluoroscopy. But before we do that, let's explore some of the current robotic platforms and their ability to integrate with imaging. So let's see. This is a video from the good Dr. Pritchett showing on a mannequin the use of cone beam systems and being able to combine with the ion system. And as you can see from their trackball-based system and their very flexible catheter, you have an unprecedented ability to get far, and then obviously a stability with even needles at flexible, tight angles, and also the scope being stable. And that's one of the big things that robotics brought to us was stability in the periphery and the ability to make micro movements. A similar case using the Monarch going after a small nodule here. Let me just click on something here. Or not. There we go. Just give me 1 second. Sorry about that. So what you're going to see here, and this is where the need for imaging, because this was the needle hole that we first passed. And you can look, we're seeing inside the lung, but we were non-diagnostic. And it's because, even though it says we're close to it, and we had CT to body divergence that was keeping us from where we wanted to be. And when we looked at the radio probe, we were still eccentric, even though we were through the lung. So when we mark down, let me go deeper down into the video, instead, we moved further down and created a second hole, now in the correct location. So this is showing you some of the advantages of robotics, that the stability, the ability to see and be able to see these holes. But I had to fish around for this small lesion because CT to body divergence was holding me back. So that's where technology like lung vision shows up, where this is a tomo view. Now you will notice that this view is not as crisp as some of the cone beam views you've seen, but I can still see my lesion compared to the reference X-ray. So, it's great to have a Ferrari, but, I just need a regular car to get to work. And so having the ability intra-op to see that I'm in the lesion, and that's where you get this tool and lesion confirmation. So you can quite literally see that your needle is inside, and then what that translates to is intra-op augmented fluoroscopy, where you have pathways, but as you can see your scope, and this of course can be any scope. In this particular case, it's a robot, but this works with a thin scope or anything else, and all of the robotic platforms, and I can see then, no matter what plane I'm in, my needle is inside that yellow ball. And that yellow ball I placed there in real time using tomosynthesis. So to go back to what Bobby had commented on in his quote, saying that we need external imaging within robotics, one of the things that is currently available is the ability to add tomosynthesis to our armamentarium. And if you really want proof of just how much CT to body divergence there is, when you start a case using lung vision, for example, this yellow ball is based off the pre-op CT. So this yellow ball is also where the Monarch is telling you to go, and the Ion, and Varin, and Superdimension, and Lung Point, and everywhere else. To pick a software. And honestly, even your own study of the CT scan. Now, I think all of us can see under fluoro the actual lesion. And so after we did the TOMO update, you will see obviously the yellow ball move where it should be, which then means as I'm navigating, I now know exactly where to go target. There is no virtual representation. That is the lesion because I just did TOMO to prove it. And what that lets you do, just for final confirmation, Mike last night spoke about negative predictive values, meaning the value of saying that, fine, I didn't find cancer. Is anyone going to believe me? And if I can prove that I was dead center in that lesion and have video proof that I was dead center in that lesion. So here we've got a probe inside our small little lesion that we're focusing in on. And then what you'll see after we've confirmed it is this. And this is just using a regular GEC arm. And you can see that you're inside the lesion. So when I get granulomas and everyone says, you must have missed. Well, there I am in the middle of it, so it's hard to say that I missed. So do we have any data? So this was our first 45 cases. We've now done about 150 with the robot and lung vision, but this was a presentation our fellow put together. I think what's interesting is that when we used lung vision combined with the robot, this was on immediate on-site rows, 84%, but then the final diagnostic yield hit 91, and the nodules ranged from 4 to 35 millimeters, but on average were about 16 millimeters. And you'll notice right up front, we had specific, this was the immediate diagnostic yield with rows, and then using similar to benefit and follow-up, we were able to achieve a yield of 91% for our final diagnostic yield, and all of that is enhancing the underlying C-arm that we already own. So adding external imaging to a robotic platform is the key. And that's what, again, part of last night's discussion was using mobile cone beams and larger cone beams integrated with robotic platforms like, for example, what's available in the Ion system and so forth. But all of these are still relatively external. And so recognizing an unmet need, there's another robot that's soon going to be released in the US and then obviously around the world, combining some other components to it. And so adding fluoroscopy directly into the robot, meaning adding tomosynthesis, the ability to see that you are in the lesion, similar to what we've demonstrated already with some other platforms, the ability to have augmented fluoroscopy built in so that after you update the lesion location, the virtual representation that you're driving towards gets updated so that you can then also know how far you are from the middle of the lesion. So extremely promising opportunity. I say promising because, of course, it's not yet FDA approved. It's only being currently used in humans in a first-in-human trial in Australia as we speak. So what I can only show you is an animal study that will soon be published, and several members in our group here were part of this study, including Dr. Badra and Dr. Mahajan and myself. What I will tell you, and we can all, it's an animal study, so we can pick it apart, of course. But the average size lesion was 16 millimeters. Most were about 7 millimeters from the pleura. I believe only 2 of them had an airway sign, so majority were eccentric off airway. You can see that what the plan was as a pre-op procedure CT, and then the ability to say we were in the lesion. And the primary outpoint was then using cone beam to prove that we were indeed dead center. And tool inside the lesion was at 95%, and 5% was the tool was touching the lesion. And the diagnostic yield, being able to pull out a purplish material that had been injected into this, so obviously again artificial, was 100% on all lesions. Now, all caveats. Animal, these were 4 experienced robotic users, going after 5 lesions per animal, separate animals, etc. But how do these all compare? So right now, the 2 robotic platforms represent what's currently available and are 2 separate components, and I'll put a comparator up in a second. One key difference is it's all on one cart, so it's less of a footprint. When you want to take a look at the different mechanisms at which they drive and scope diameters, there they are from a comparative perspective. Differences in the vision, difference with integrated imaging, especially with the built-in tomosynthesis. One key thing on the Galaxy is the catheter is disposable, so there's no issues with cleaning and reprocessing that currently besets the two first-generation scopes. Okay. So that's what's also new and exciting in robotics. Several of us in this room will be obtaining this device in a limited market release once approved. So again, if you're in the US, please come visit. Lastly, of course, the other promise of robotics is therapeutics. And I say therapeutics, meaning just obviously the idea that we're going to treat something malignant. If not for cure, then maybe for enhanced immunogenicity effect. And this is the list that I could come up with, and there's probably a couple others I'm forgetting. Sky's the limit on this. This is actually a relative Wild West, I think, in regards to what needs to be done here. And I think we do and owe it to our patients to do some excellent studies to figure out what's the best approach, what's the safest approach, especially if we're looking for curative intent. But I'll give you one example of where obviously having advanced imaging was the key. Mike's paper was recently published on the first experience with New Wave and using cone beam, and it's an excellent read and worth exploring. So here's an example of, here we're using a nanoparticle. And the short of this is that this nanoparticle enhances radiation and the dose. So in other words, standard dose is given, but it enhances it at a cellular level and leads to a higher rate of kill. So this was the case. We were asked to go plant these particles inside this thing. And it's not the most challenging location, et cetera. It's a doable lesion. So the summary of it, this is what it looked like after we put them in, and I'll show you how we did it in a second, but it obviously becomes very radio enhanced. So we navigated out. We had a nice eccentric rebus view, but we also, you'll notice here, by using our lung vision system, we're then able to make adjustments to guide our needle directly into the center so that we could inject these nanoparticles. And like I think all forms of ablation, it's the precision that matters, or in this case, injection of a particle that's going to enhance radiation. You can't have this spilling into the airways. You're going to create a massive effect. This was the immediate follow-up CT after his first radiation treatment. So, if you recall the first lesion. So extremely optimistic in regards to what it potentially could do. And again, I have no skin in this game in regards to what makes it, what doesn't make it. I think as a bronchoscopist, I don't really care if RF or microwave or cryo or nanoparticles or poration or who cares? My job is to get to the lesion. Put whatever device inside said lesion. Step on pedal. Nice to see you, right? That's my skin in this game. I'm here to deliver whatever somebody else tells me is now the official best way to treat the tumor. Happy to do so, right? So with that, and I'm finishing early, I got 2 minutes, I'm going to say thank you, and I'm going to unleash you for lunch. Here's my contact information, and again, thank you so much for your kind attention.